of why we need to look at this. If you are anywhere close to practicing age-related medicine or anti-aging medicine or integrative medicine or holistic medicine, because this is one area where most of us practitioners get it wrong. Whether we are coming from the mainstream, whether we are cardiologists, whether we are neurologists, please remember, a large number of people suffering from a whole lot of issues in cardiology, in neurology, even with prostatic cancer, would not have suffered if early on we could detect the decrease in testosterone and its problems that it causes. And we're going to look at this particular session today. We're going to look at it. We're going to understand a little about what happens in the physiology, what happens when there is lack of testosterone, and a little about how you can supplement it, and what are the pitfalls of supplementing with testosterone. That means you need to understand what is it that you can create which is bad when you do testosterone supplementation. So I'm going to touch on 4 areas right through the session, in not particularly the order that I've said, but you will get all these in the session that I'm going to do. That is the basic idea, because one of the biggest misnomers is people don't know how to supplement testosterone properly without actually looking at what it can cause. And I will show you how and what happens, all right? So let's get started. Let's understand the normal physiology first. This is a very crude representation of how the entire hormone system works, and therefore you need to understand that it is the LH that is required for the production of testosterone. So you get it stimulated by the pituitary hormone via the LH. Testicles mainly produce the testosterone. However, a good amount of it, rather not too much, but good amount of it, is also produced by the adrenal glands and other tissues. For example, the fat cells. Conversion from androgens like DHEA and androstenedione. Now, you need to understand that there is also a circadian rhythm that exists in the body. You will have a 20% higher level in the mornings than in the evenings. And those of you who practice and would like to ask for history, if your male patient does complain to you that his early morning erections have suddenly gone down, that is a sign that testosterone has gone down. That's because testosterone is 20% higher in the morning than in the evening. Always remember that intensive burning of testosterone takes place when you have frequent sex, long distance running, any kind of heavy exercise, including gym exercising. But when you do burn a lot of testosterone, you also make a lot of testosterone, and therefore it is a good thing to burn it. What happens is if you have too much of emotional stress blocks the release of LH, and thus testosterone decreases production in the testes or in the cells of Leydig. So you have to remember, too much of emotional stress causes a block in the release of testosterone. First, the release of LH, the luteinizing hormone, and then decrease in testosterone, obviously. Now, what are its main functions? One of the major functions, and I've been using it for such a long time because a large portion of my practice has been cardiovascular practice. And that's what attracted me to testosterone so much. A large portion of it goes to help your cardiovascular system. It makes your heart stronger, widens the lumens of your coronary arteries, increases the blood supply to your heart. So anybody suffering from any kind of ischemic heart disease, testosterone is one thing that you need to look at. reduces serum cholesterol and minimizes atherosclerosis. Very good thing for if you have an echo which says that your arch of aorta or has some amount of mild atherosclerotic changes seen, just check this person's testosterone and put him on some testosterone supplementation. It reduces hypertension by vasodilation, makes blood more fluid, increases fibrinolytic activity, so it stops clot formation. So the chances of you having plaques and thrombi, which sometimes lead to deadly heart attacks, go away. It protects against obesity and diabetes. If you're pre-diabetic, good chance you will be low in testosterone, and this is one way that you can reduce the chances of you becoming a frank diabetic. It decreases severity and incidence of both obesity and diabetes by reducing the fat mass. It increases lean muscle mass, but you must remember that if you are giving any amount of testosterone, and testosterone has to work on lean muscle mass, you need to ensure that some amount of exercise and physical activity is required. It increases insulin efficiency and helps glucose penetrate both the brain, muscle, and the heart, and all the other tissues wherever it is required. Are we getting this so far? Can we have a few yeses? I don't know if everyone's gone to sleep. So are you understanding so far? I've given you a very, very important. Can we have a few yeses in the chat box? I'd like to see as many people answer as possible. Thank you. Thank you for those responses. Thank you. Thank you. Thank you. Now, it also ensures, so if you realize I put the reproductive health second, most important was the cardiovascular health, because when we look at an aging at the age of 35, 40, this is where testosterone comes in most important. I mean, you can reduce this person's aging, premature aging drastically if you catch it at about 35, 40 before he starts getting all the chronic degenerative disorders that are going to keep him sick for a better part of his life. It develops and maintains reproductive health. So that is much earlier in life. It ensures your penis size is correct. You have a good sexual potency. Your prostate is good. Always remember, high testosterone does not cause prostate problems. And I will explain to you how prostate problems are caused. So just wait and hold your thought there. It is responsible for body hair. It is responsible for the sperm count, fertility, and good testicular function. Supports brain and nerves by increasing blood supply and the number of connections between the neurons. So it plays a huge role in the cognition. Your brain starts functioning better if you have enough testosterone levels. Always remember something. All sex hormones, progesterone, estradiol, testosterone, all work on the brain. They have more number of receptors in the brain than any other part of the body. In the brain, testosterone plays a huge role. It will keep you as a calm mind, confident. You take decisions better. Brain fogging as you grow older go down. And as you go along, you'll see that there is a lot of literature to show you that if you have enough testosterone supplementation, you may even avoid Alzheimer's if you are a pre-Alzheimer's, and reduce the rate at which Alzheimer's goes. I'll show you that as well as we go along. It sustains bone density. Yes, it improves your bone density, it improves your strength, it improves your muscular mass as well as strength and skin blood supply and sebum secretion. So that is what you see in young kids during their when they're between the age group of between maybe 12 and 20. Yes, so they do have a lot of sebum secretion. As you grow older, this sebum secretion is not seen too much, but yes, testosterone plays a huge role. Like I said, it improves your mood, memory, it reduces anxiety drastically. Now, you can forget everything I say today. Don't forget this diagram. It's very, very, very important if you're going to use testosterone in your practice. When LH causes the production of testosterone, about 5 to 7 milligrams per day, goes through hepatic oxidation, conjugation, and goes out through renal excretion. This is the inactive pathway. A good majority of it goes to what we call the direct pathway through the androgen receptor, where it does its normal work. Now, what you need to understand is a good amount of it, which is a very small percentage actually, gets aromatized to estradiol. And this is the one and only time that you will have side effects, when it aromatizes to estradiol in the presence of aromatase, and it gets converted into DHT, that's dihydrotestosterone, in the presence of 5-alpha reductase. That's 5 to 10% of the testosterone, which is made 5 to 7 milligrams, goes to become DHT, and a proportion of it goes to become aromatase, estradiol, because of aromatase, because of the aromatase enzyme. It aromatizes to estradiol. So this is the only place that testosterone gets converted into estradiol. That's your liver. Now, this one thing you need to keep in mind when you're supplementing testosterone. Any side effects of testosterone come from conversion to estradiol or conversions to DHT, as we see. So when you block both these enzymes, aromatase and 5-alpha reductase, you cut out these side effects of testosterone supplementation. Because when you supplement testosterone, the chances are part of it gets aromatized to estradiol, part of it goes, or in some, it will never happen in both will never happen in the same patient. In one patient, you will have a lot of it getting aromatized to estradiol. In other patients, you will have it converted by 5-alpha reductase into DHT. Are we getting this? Are we getting this? Because the moment you have testosterone converting to estradiol, your prostate enlargement starts. The moment you have testosterone converting to DHT, you start getting bald. So these are the two things that you need to remember. You can forget everything else. You need to remember these two very, very important things that happen, or the two important pathways that testosterone takes when you supplement testosterone. You need to keep this in mind. In fact, all the bad literature against testosterone is because of it aromatizing to estradiol. If we take care of it, testosterone is the safest supplement, giving you a wide range of benefits for good health for your patients. So this is what exactly happens when when testosterone gets aromatized to estradiol. You have what is now called as man boobs, or you have the most important and the dangerous thing, prostate enlargement, right? Which nobody wants. And if you have DHT, where you have 5-alpha reductase playing a part in there, then you have loss of hair. So both these can be blocked while you are supplementing testosterone, and we'll see as we go along. So aromatase and 5-alpha reductase are the two that are responsible for testosterone converting either into estradiol or into DHT, okay? Now, androgens exert effect on virtually all body tissues and have a multitude of physiological roles in health, and we know this. When testosterone is deficient, it leads to a multiplicity of symptoms and signs that can be corrected with a physiological substitution. That means you need to give that much that only gets your levels up to a physiological level. And this was well documented in 2009 in a journal called Menopause, where the researchers spoke about testosterone therapy in men. Approximately every 4 seconds, a Leydig cell dies without being replaced. Leydig cells are where your testosterone is made. Of the 700 million Leydig cells at 18 years, only about a third remain when you are 70 or 80 years old. Free testosterone decreases by more than 50% in urine and blood as you start aging. Now, what is male menopause? Right? What is it? Androgen decline in aging male. Its synonym is Adam. It's late onset hypogonadism. It is less sudden in onset than female menopause, but let me tell you, its consequences are far, far more severe, if not just as severe. And the cause is decreased bioavailable testosterone. And we'll see what bioavailable testosterone is. Now, male menopause, or andropause it is called, the moment you hit that, you will have these problems. And these are some things that you see very, very commonly in most males who hit andropause or male menopause very early. Increased aging of heart and its circulation. So the chances of increased myocardial infarctions, increased cerebrovascular accidents and strokes, decreased hemodynamic function. So you will see the heart showing you diastolic dysfunction and slowly systolic dysfunction. Then there is brain aging, and this brain aging starts galloping fast. You have decreased memory, that's one of the first signs, decreased intelligence or cognition, increased dementia and Alzheimer's in most of these patients. Loss of drive and competitive age. This is the first symptom that the patient comes to you with. He complains saying that I don't have drive. I used to get up in the morning and go for my exercise, don't feel like getting up in the morning. Stiffness and pain in the muscles and joints. This is another thing that they come up with. And you say it could be arthritis. It isn't arthritis. Your levels of fitness start falling. You don't feel like working out. And even if you force yourself to work out, you, instead of losing weight and developing muscle, you start putting on weight and flab. That's because you are over-exercising at times and causing a lot of cortisol release, which causes you to put on weight rather than lose weight. So this is what happens when your testosterone levels start falling. You have a deteriorating body composition with sarcopenia, less muscle mass, and more fat. Osteoporosis sets in a little later, somewhere after 50, 55. And if you have a male who comes with anemia, always check his testosterone levels as well. Now, one of the earliest signs is also fatigue and tiredness. So if you have a 35-year-old, 40-year-old saying, I get tired very easily, right? I can't finish my work for the day, check his testosterone. Depression and mood changes is another very early sign of male menopause. Constant irritability is something that you also see in these patients. You have reduced libido and potency, decreased desires and fantasies, decreased morning erections like I told you, decreased erectile tension, longer recovery time between orgasms, and decreased intensity of orgasms. All this are complaints that you will see a little later. Initially, it is fatigue, it's irritability, it's depression, it's mood changes, it's tiredness, it is lack of feeling of exercise, it's you don't feel like doing anything. All these are signs that you will see first. You have to look at these signs and complaints and straight away check whether this patient has adequate amounts of testosterone. Half of the healthy men between ages of 50 and 70 years will have their blood testosterone levels below the lowest levels seen in healthy men who are between the age of 20 and 40 years of age. This was actually recorded way back in 1990. Just to show you where the prostate lies, and for those of you who need to get a little bit of an embryology refresher, the origin of the female uterus and the male prostate is the same. So if estradiol will go and increase the cell mass in uterus, it will also do the same in the prostate. So always remember, this goes back to our embryology. The embryology tells us that both the prostate and the human and the woman's uterus come from the same cell origin. So they get stimulated by the same hormone, and that is estradiol, right? Always remember that. And that is the reason why you cannot have your testosterone getting converted or aromatized by aromatase enzyme to estradiol. I keep saying this because it is one thing that you need to take from this lecture. It will help you to use testosterone very, very effectively. I've never had issues with my patients who use testosterone. It is because we always ensure that that this aromatization and conversion to DHT is not happening in them. We always ensure that. And I'll show you how to do it in this lecture. Now, what happens to testosterone in an aging male? Let us look at that as well. Testosterone is androgenic hormone formed in the testes in a young male. Aging brings a decline in testosterone and activates 5-alpha reductase and increases DHT. That is the reason why as you age, you start losing your hair, because you have a decline in the testosterone, and a testosterone gets converted to DHT by 5-alpha reductase. Now, escalating amounts of something called endocrine disrupting chemicals, or endocrine disruptors as I call them, are very, very, very important in today's world. If you don't pay attention to them, you will not be able to help your patients. These endocrine disrupting chemicals actually have powerful testosterone lowering abilities, or what we call gender bending abilities, that lower the testosterone, lower sperm count, lower Leydig cells. They destroy everything that helps you maintain good health. Now, let us look at this in a little better. What are these endocrine disruptors? If you look on your screen, everything that you currently use, all the plastics, your plastic bottles, your plastic food containers, your plastic wraps, every one of them has got what is called bisphenols, phthalates, your detergents, vinyl flooring, plastic soaps. Bisphenols are one of those that create such a big impact, because every food item of ours has got some amount of plastic in there, and plastic has got bisphenols, whether it's plastic bottles, the water bottles, the containers, all of them have got bisphenols. They are all endocrine disruptors. Insecticides and fungicides that go onto your food also are endocrine disruptors. Fluoride in your toothpaste is an endocrine disruptor. Unfermented soy products is something you should never give a male. And pharmaceuticals that provide synthetic hormones are also endocrine disruptors, right? Now, when you do a lab test for total testosterone, for males, it should be 350 to 1030 nanograms per deciliter. In females, it should be 10 to 55 nanograms per deciliter. There is a whole session of testosterone in females, which I will not touch in this session at all, okay? So you need to look at your lab, look at your reference ranges, but remember, reference ranges are not optimal ranges. Whatever reference range that your lab gives, if it gives you at 350 to 1030, then for me, the optimal range of testosterone for that patient will be the upper third of this reference range. The optimal range is always the upper third of the reference range, and you want your testosterone levels to be there or even above that, doesn't matter. I don't do too much of salivary testing in India because we don't have it, but if you get it there in Indonesia, please, you can use, these are the levels that you need to touch, salivary testosterone, this is again total testosterone 100 to 720 picomoles per liter for male and 29 to 190 picomoles per liter for females. Okay, so this are the normal levels that you need to get your testosterone levels in. Always within these reference ranges, you need to aim to hit the upper third. Have we got so much, please? Can we have a few yeses? I want to know if you're understanding what I'm saying. Just type a yes in your chat box. Let me see how many people have been. Thank you, Dr. Nanare. Thank you. Thank you, Dr. Lee Sankey. Good to see you here. Thank you to all of you who have responded. Yes. All right, so let's look at what we have next. So the total testosterone has a circadian pattern like I told you. So if you need to test total testosterone, always do it in the morning session. It's automated, it's always consistent, so you'll never have a problem. It may not relate to free testosterone because free testosterone depends on sex hormone binding globulin. It may also not correlate to bioavailable testosterone depending on, again, because bioavailable testosterone depends on sex hormone binding globulin and albumin, right? Now, sex hormone binding globulin binds to testosterone far higher than estradiol. It should be about 20 to 60 nanomoles per liter in males and 40 to 120 nanomoles per liter in females. If you want to check the free androgen index, always go with testosterone multiplied by 1,000 divided by the value of sex hormone binding globulin. This is just for your theory. I don't know if you'll ever use it. But you need to understand that if sex hormone binding globulin increases, the amount of your free testosterone that remains bound is higher. So you don't have too much of testosterone available for it to work in your body. What increases sex hormone binding globulin? Thyroid, estrogens, progesterone, and aging. Now, estrogens and progesterone cannot be in high levels in a male. The moment they start going up, you start having problems. Why? Testosterone goes down, heart disease starts. So it's all interrelated. What decreases sex hormone binding globulin? If you have good amounts of total testosterone, if you have good amounts of glucocorticoids, especially cortisol, if you have good amount of growth hormone, and if your insulin is adequate, you will have SHBG going down, that's sex hormone binding globulin decreasing. So higher the level of sex hormone binding globulin, the chances are that you will have lower testosterone levels, lower free testosterone levels, and you will have patients complaining of andropause symptoms. Now, free testosterone is what we look at between 80 and 300 picograms per ml or 80 to 30 nanograms per deciliter in male. Keep these figures with you because depending on which lab you will get, these are the figures that you will get. For a female, it is 1.1 to 6.3 picograms per ml, okay? So these are the levels that you would want. Now, fraction of testosterone that is unbound to albumin and globulin is what is called free testosterone. Now, free testosterone, every endocrinologist will tell you, is not a reliable figure that you would get from a lab because the accuracy differs depending on what kind of method of testing you use. But they say the best is equilibrium dialysis or ultracentrifugation. The others are kind of inaccurate. Even this, there is a question mark. And therefore, there was something called bioavailable testosterone that came about. Again, I don't get these bioavailable testosterone calculated and given to us by labs here. It is 120 to 600 nanograms per deciliter in males, which should be normal, and 2 to 20 nanograms per deciliter in females. Now, what is bioavailable testosterone? It's free testosterone plus what is loosely bound to albumin or albumin testosterone. This is calculated, and generally this is what we would like to call the most useful number, because this is the one that actually tells us how much of testosterone the body can actually use. If this is less, even if your total testosterone is normal, then you need to take measures to ensure that your sex hormone binding globulin comes down. You may still need to supplement testosterone, because higher the testosterone SHBG goes down, the more is your free testosterone available or bioavailable testosterone available. So even if your total testosterone may come to a upper third, if your bioavailable testosterone or free testosterone is very low, you may still need, and your SHBG is high, you may still need to supplement it. Always remember this. Now, the relative potency of androgens, you see DHT has got the highest potency. So if you look at people who have got high amounts of DHT, they will tell you they have got the best erections, but they also have a lot of other problems that they have. Besides getting bald, there are other issues that take place. DHEA and DHEAS have got far low potency, and androstenedione, of course, is at 10. So you can see these are figures just for you to understand. Again, I'm coming to you. I want you to remind you, testosterone can go into the inactive pathway, the active pathway. Most of it goes to the androgen receptor, but a part of it gets aromatized to estradiol, or a part of it will get converted to DHT by 5-alpha reductase. So remember this. I put this again. Don't forget this. DHT and estradiol levels and what should be the normal levels as far as males are concerned. So if you want to test DHT, it should not be more than 30 to 85 nanograms per deciliter. In females, it should be 4 to 22. Optimal should be 15 to 40. It should not cross 40 in males. Estradiol should not be more than between 15 and 45. I prefer the estradiol levels to be less than 25 picograms per ml. There, yes, correct. Optimal is 15 to 25. I prefer them less than 25. Anything above 25, if I'm supplementing testosterone, I will give aromatase inhibitor. So you need to measure and control both of these levels in men when you're supplementing testosterone. It's not enough to check the testosterone levels when you're doing supplementation of testosterone. You also need to check DHT and estradiol and control them. And I will show you how to control them. There are ways to control them. Now, these are the salivary levels. You can just click your snaps if you want to. I don't use too much of saliva here because we don't get it, but I think in Indonesia, you get saliva levels. They are more accurate. They are faster. Always remember, serum levels are to be checked after 2 months, at least 60 days, because by the time serum starts showing changes, it will take some time. Whereas saliva will show you immediate, so you can check your salivary changes even 15 days after you start the supplementation to see if anything is going wrong. So saliva is a better way of doing it, but you don't get it accurately everywhere. So DHT should be 2 to 10 picograms per ml. 1 to 5 is optimal. Estradiol should be less than 6. Less than 4 picomoles per liter is optimal for males, okay? Now, estradiol can chase testosterone. What do I mean by this? What I mean is, when we are supplementing testosterone, if testosterone is going up, you can have high amounts of estradiol in your body as well, because it chases that number. So you need to keep it optimal less than 25 picograms per ml or less than 4 picomoles per liter as far as saliva is concerned. So how do you go about ensuring that your testosterone does not get converted to estradiol? I've given you 4 substances that inhibit aromatase. if you are giving testosterone supplementation, you have to know that one of these have to be in your armamentarium to give this to the patient. Chrysin 250 milligrams twice a day. Zinc anywhere between 50 and 100 milligrams per day causes aromatase inhibition. Progesterone 5 to 10 milligrams transdermal. It is a very, very small dose. I have seen people giving so high doses to males that they start getting other issues. Progesterone should be very, very low when you're giving it for aromatase inhibition. And the most easily available, because if you don't have a good zinc salt, you may not be able to get the proper aromatase inhibition. But the one, if you are really wanting to stop the aromatase inhibition, especially when the patient is getting sick fast, you can actually...
Halo, udah di mana, Pak?
Can we have everybody muting themselves, please? Thank you. The most important molecule that you have is anastrozole. Difficult to get, but this is what is being used for all breast cancer cases. What we do with this is we use a very small dose. Here it's put 0.5 mg. I use even 0.1 mg once a week only, and it causes aromatase inhibition beautifully. This one is available in any pharmacy, so you don't need to worry about it. You give it for about 10 weeks, and the patient is fine, and you can continue with your testosterone supplementation as you were doing. All these control estradiol production or conversion of testosterone to estradiol. It can also be given if you suddenly realize, because please understand something, you need not have only supplementation of testosterone for it to go up to your estradiol to go up. You have a patient who comes to you, he tells you that he's got maybe a little bit of BPH. Check his estradiol levels. If his estradiol levels are high, don't start testosterone on him till you get his estradiol levels low, and then start, because if you put more testosterone on him, he's going to get that converted into estradiol as well, aromatized to estradiol. So you need to use anastrozole or arimidex or chrysin and zinc to control the E2 levels and reduce the high E2 levels. I've done this for many, many patients with prostate issues, and these patients have opted not to use testosterone supplementation. But what they have benefited is that the testosterone that was getting converted to estradiol or aromatized to estradiol then starts working down the direct pathway. So they have their own innate testosterone available to them, so they may not need testosterone supplementation if you start reducing their E2 levels. Okay. So these are some of the studies on the basis of which my previous slide is based. It's all available in literature. You can check it. There are tons of it. I've just put about 3 or 4 for you. Now, how do you control DHT, especially when you're giving testosterone transdermally? So DHT is caused more when you're using a transdermal form of testosterone. Many people say it's good, but it is also associated with prostate cancer, benign prostatic hyperplasia, and hair loss. So these are the 3 major problems that you get with DHT. But the good thing about the DHT is that you get a far better erection than even with plain testosterone. So some of these people who have this DHT conversion are very happy about it. But when they start getting prostatic cancer and BPH and other things, you need to be a little careful. So you need to use inhibitors of 5-alpha reductase to keep DHT low. And what are they? Saw palmetto is one, and the dose is 320 milligrams per day that you can use. Again, if you notice, progesterone transdermal 5 to 10 milligrams is another one. Now, you have to be very judicious if you're using progesterone. It has to be good quality, and you have to be able to. If I were to use progesterone, I would not depend on serum. I would depend on a good lab to give me salivary testing every 15-20 days, especially when I'm starting a new patient with testosterone supplementation. All right. Now, this you can get over the counter or on a prescription from a doctor from any pharmacy. Dutasteride is used for all BPH patients. It's easily available. You give it once a week instead of daily, or twice a week, and again it will stop. It will inhibit 5-alpha reductase. Okay, it is a good chemo prevention kind of a tablet with which prevents prostate cancer. If you have BPH and you're giving dutasteride, this is one agent that does that. But more importantly, you can use it for just reducing to inhibiting the 5-alpha reductase and stopping the conversion of testosterone into 5-DHT. Okay, sorry, into DHT. Have we got this? Have we understood the aromatase and 5-alpha reductase inhibitors? Can I have a few yeses? Thank you. Thank you. Thank you so much. So again, I have listed out for you a whole lot of studies on the basis of which my earlier 2 slides are. Now, when you give testosterone supplementation, you do have good bone density. You can see the eugonadal man on your left-hand side. The bone density is much better than on the hypogonadal men. One is 28 years old, one is 31 years old. Always remember, good testosterone, good bone density. Now, methods. Before I go further, let us understand how can we supplement testosterone, all right? So I use a lot of injections when I don't get transdermal. I also use gels which are commercially available. I hardly get pellets in this country. So let us look at what are the good ones and how to go about it. So when we look at injections, you have enanthate and cypionate. And now, of course, you get a lot of others with 3 or 4 different sorts of testosterone together. The earlier method was, once in 2 weeks, give a large dose that would give you supraphysiological levels for some time, and then it would go down, and a large portion, because of the high amounts of testosterone coming in at one shot, a large portion of it could get aromatized to estradiol, and you would have problems of both prostatic hyperplasia, prostatic cancer, etc. Prostatic cancer will never come from testosterone supplementation. It always comes from aromatization to estradiol, and that causes cancer, right? Less DHT increases seen in injections because it is not transdermal. So now what we do is we give you a much smaller dose, but we give you a weekly dose of 100 milligrams, and you can give it for about 10 weeks. The physiological levels are more stable. They are less issues with aromatization to estradiol, and you have less problems if you are giving it weekly and a smaller dose. So any injection, 100 milligrams over a period, except for undeconate. I'll come to undeconate. Undeconate is a long-acting form of testosterone that can be given once in 45 days. Oral methyl testosterone is hepatotoxic. Why? Because anything given oral will get thrown out in the first pass effect, and it will create hepatotoxicity. The liver will throw it out. Oral undeconate andriol, I have not used it much. So the undeconate salt does not go through the first pass effect, so you will not have hepatotoxicity. But I have not got very good benefit of undeconate, so we don't use it orally. I have used undeconate as an injection, which is given over a period of, I do 3 injections every 6 months on day 1, day 45, and day 90. So if a patient is coming from overseas, Instead of giving them weekly doses, we give them on day 1, day 45, and day 90, and that suffices them for at least 6 months to a year. Okay, so undeconate is a long-acting one. It's IM. It is painful, but if you have a good nurse who knows how to give deep IM, it sorts your problem. I'm very bad at deep IM. This is fat-based, so it's very, very painful. Pellets is something new. It's a minor surgical procedure, lasts 2 to 3 months. I have not used them much because you don't get levels and you don't get them in India. If you do get them in Indonesia, please explore them. They are good. Always do your tests every 15 days, especially if you have salivary tests available, to see if there's any aromatization taking place or any conversion to DHT taking place. Buccal BID, yes, you have some buccal pellets, this thing that you get. They achieve good levels. I have not used them much. There is a lot of data on that. That's why I just put it down. Transdermal is something that we have all used to. We have been using it for a long time. It's well absorbed in most men, proven with serum levels going up. You have more DHT being formed because of hair follicles containing 5-alpha reductase. So you have to apply it in areas where there is less hair. Preferably, if you can get a transdermal cream with a little bit of chrysin in it, you can avoid this. It gives you a steady state for 24 hours. It's a slow absorption because you're using a liposomal cream. There are patches available. They are okay, but they're very expensive. I've not had too many patients liking it, so I've not used it much. I have used the gels that are available commercially, 100 milligram packages or 75 or 50 milligram packages. They have given me some benefit. When I don't get transdermal, I go into an androgel. They are available commercially, so it's easily can be used. But most compounding pharmacies can also give you transdermal gels, less expensive than androgels that you get in the market. Also, a compounding pharmacy can titrate the dose depending on what your patient requires. And most importantly, when you can do a little bit of titration of your dosing, you get better pinpoint results and therefore preferred by most men. Now, when you do a compounded gel, 1 gram equals 4 pumps. That is depending on what kind of pump you use. This is something that we use. So 1 gram, 10% equals 100 milligrams. So 4 pumps will give me 100 milligrams per day production of testosterone. You can always titrate this dose up and down depending on the salivary testosterone or bioavailable testosterone or any clinical results that you depended on before and after. So always testing is very important. Always avoid gels or creams on scrotum because it increases DHT. Avoid getting gels on females and kids. Always rub it well over a large surface area. Increase in hair growth in the area of application, but it never increases on the head. So remember, if you're applying it on your body, there will be an increased area that the hair growth may increase there, but on the head, it will never increase. Total free bioavailable testosterone can actually decrease with gel. Always remember that. Total androgen may increase if you add too much testosterone. That means it can get converted into DHT and DHT can go up. And sometimes you have a lot of males complaining that the gels do not absorb. So I still prefer creams. They are much better. Many patients use HCG together with testosterone. I don't use it. I've put it here because you may have some of your patients using it. The benefit of using HCG or sublingual applications, which are precursors to HCG, is that your human chorionic gonadotropin improves LH and FSH and thus increases the own innate testosterone. That's why I've just put this here. In case the patient does add HCG, it will help in improving LH and FSH. Now, New England Journal of Medicine, in a testosterone review, said that you can actually do give testosterone for an aging adult, provided you monitor it properly. This was in 2004 for the first time, a positive review that came out from a conservative medical journal. Now, when you give testosterone replacement, what do you expect in the erectile function? Your libido goes up, nitric oxide receptors are upregulated, you have an improved erectile function, but these signs or these improvements may take up to 6 months. And if the patient is a frequent user of sildenafil or any of those, then the response to sildenafil starts improving drastically. When you use testosterone, also you see cognitive function improving drastically with testosterone replacement. And there's a lot of evidence, which I have put down there for you. There are 2 studies which corroborate that. Testosterone prevents the production of beta amyloid precursor protein in men. So it stops the production of beta amyloid seen in Alzheimer's, and therefore reduces neuronal secretion of Alzheimer's beta amyloid, which is well documented in the study that I mentioned there, which is published in 2000. There was a study done where there was one group that was treated with testosterone replacement, another group, which was a control group. The testosterone replacement group improved. Alzheimer's, nobody improves. Testosterone replacement group improved. They improved. They were, instead of going downhill, they stopped and they reversed a lot of their disease. The control group deteriorated as was expected. This was published in 2003 in a study called a pilot study on effects of testosterone in hypogonadal aging male patients with Alzheimer's disease. This was in a magazine called Aging Male in 2003. An awesome study. If you can get hold of it, go through it. It will show you that testosterone helps Alzheimer's, especially in early Alzheimer's in males. The lower the free testosterone, more likely you have coronary artery disease. So testosterone improves exercise-induced ST depression. This was what was seen in studies done in patients with angina. It dilates coronary arteries. It has an effect on the lipids. Most current studies, of course, are showing that there are not much of change with lipids. But if you are using testosterone properly, most patients will show you that their cholesterol levels go down, specifically if you have got LDL levels which are very, very high. Also triglycerides, which are very, very high, they start coming down when you are using proper testosterone replacement. Of course, there are certain studies now that are saying that there may be no change, but we have to see whether they were done in a particular manner. I have seen my patients showing good results with that as well. Low testosterone is associated with dyslipidemia, which means that if you have low testosterone, chances are that you will have bad cholesterol levels. Generally, I don't have too much of a problem with bad cholesterol levels. I'm more interested in looking at lipoprotein little a. But even lipoprotein little a improves if your testosterone levels are okay. Now, testosterone reduces angina. This was a study done. It is mentioned the study is a controlled study. It's a randomized double-blind placebo-controlled study which was done with low-dose transdermal testosterone therapy, just to show that, and it showed that it improves angina threshold in men with chronic stable angina. So What happened? When you applied testosterone over a period of time, exercise-induced myocardial ischemia reduced. There was a significant improvement in pain perception and role limitation from physical problems. There was no change in lipids, coagulation, and hemoglobin. That was what was shown in this study. 5 milligram patch used, androgen levels doubled. Okay. In testosterone, in the same exercise, it showed in the same study, it showed that exercise-induced myocardial ischemia reduced, so angina reduced. Significant improvements. Okay, we've seen this. We've seen this. It's a double side. I'm sorry. Testosterone and cardiac ischemia. So this, in another study, they actually removed anti-anginal treatment. So patients were getting nitrates. They removed the nitrates out of these patients. Some were given a placebo. Some were given IV testosterone, 2.5 milligrams. This is a very small dose. And they were both subjected to stress tests. What they realized is there was less chest pain in the testosterone control, so there was no ischemia, and there was an increased time to ST depression. That means ST depression happens when there's ischemia, so the time for you to get ischemia was much longer in patients who had IV testosterone given to them. Have we got this?
Yes, I got this.
Catherine, can you mute yourself, please? Thank you. This was another study that was put out that short-term administration of testosterone reduces beneficial effect on exercise-induced myocardial ischemia in men with coronary artery disease with effect that may be related to direct coronary relaxing effect. Here, this study was published in Circulation, which spoke about a direct effect on the relaxation of the coronary arteries. So it plays a huge role in older patients who have severe ischemia, especially if they have already done an angioplasty, a bypass or chelation or whatever, still getting problems with the heart. Check their testosterone levels, start them on a low dose, ensure that you give chrysin and zinc so that it doesn't aromatize, and you will see there's a huge difference in their ischemia level. The ischemia will come down, they will stop having chest pain. This is one way that you can use hormones to actually control cardiac functions as well, or cardiac symptoms as well. This is another study that talks about the same coronary artery dilatation, increases coronary blood flow. This was a study done and was published in '99, again in Circulation. Multiple studies have failed to demonstrate exacerbation of voiding symptoms attributable to benign prostatic hyperplasia during testosterone supplementation. This one fact you need to remember. Testosterone does not cause any prostate problems. Multiple studies have failed to prove this. And this is what exactly the slide says. It does not cause any cancer as well. There is no clinical evidence that the risk of either prostate cancer or BPH increases with testosterone replacement therapy. This was published in the Mayo Clinical Proceedings in 2000. So remember, you can have testosterone replacement without any issues, provided you ensure that testosterone does not get aromatized to estradiol or gets converted into DHT. And I've shown you how you can stop that. Higher testosterone, the chances are that you have less prostatic cancer. Higher estradiol, the chances are that you will get more prostatic cancer. And this was in a study that was put out in 2004. There is no evidence that exogenous androgens promote development of prostate cancer. Highly controversial hypothesis that declining rather than high levels of androgens are a major contributors to prostate cancer. All this are in studies to show you that testosterone has nothing to do with prostatic cancer. And it goes by logic. I always remember my own teacher telling me this: if testosterone would cause prostatic cancer, then 18-year-olds would have prostatic cancer because they have the highest amount of testosterone. So testosterone does not cause prostatic cancer, all right? There are lots of studies. I put it down because this was one of the major things that said that you should not give testosterone to aging males, especially older males. But that study was so flawed, they just gave it blindly without checking the estradiol levels. If your estradiol levels are high, the chances are that your testosterone that is replaced will always get converted into estradiol at the aromatase enzyme. So you need to avoid that happening. And that was not done in those two studies. That was, I think, the study which was done in the case of, I remember that study, there was a lot of noise at that time in 2005. But I think even I wrote about that to the authors, and I got a response back saying that probably I was right. It was, I think, the study with, I don't remember the name of the study. Anyway, so there was a study done which created a lot of issues, but there are enough other studies that have come before and after. This one was in 2009, which says nothing has been found to support evidence that restoring testosterone levels within normal range increases the incidence of prostate cancer. So to conclude, I had 60 minutes. I think I'm just on time. I've got a minute left. So to conclude, testosterone deficiency in male causes cardiovascular disease. It can lead to myocardial infarction, coronary insufficiency, hypertension, hypocholesterolemia, and thrombosis. It can cause infertility. It can cause obesity and type 2 diabetes. It can cause depression, memory loss, Alzheimer's, and osteoporosis. So to avoid these symptoms in young adult males, please consider supplementing testosterone as your only way to avoid premature aging. Thank you, and I'm open to questions. Is anyone there or everyone sleeping?
Thank you so
Thank
much,
you,
Doc.
Doc.
For someone with voice problem, you talk so loud. That's nice.
Yeah, so I thought everyone could hear me, and we've completed the complete thing on testosterone. Any questions? I'm open to it. I just check if there's anything in the chat.
Yes, Doc, there's one question actually.
Yeah, John Su has sent out a question. I have a patient with raised PSA 7 to 8 range. Yes, I would do that, but I would also ensure that I give chrysin zinc to ensure that there is no aromatizing of this patient. Also, I would ensure that 5-DHT doesn't go up. So if I'm in a position to check 5-DHT and estradiol levels post replacement of testosterone, I will give this patient testosterone, John, even if his PSA is 7-8 range. Any more questions? Okay, yeah, I have a male patient with below 30. Plain chrysin you can try. I would rather give him zinc. But Angie, I would suggest you do his testosterone levels and estradiol levels first. Because chrysin will help you to stop the aromatization of testosterone to estradiol. Testosterone alone causes acne, so you need to understand that. And giving chrysin is not going to stop testosterone causing acne, so I don't know how that would help. I wouldn't pay too much of attention to the PSA, John, but I would keep a check on every other parameter. My main parameter would be estradiol. I won't want it to go above 25. You can check PSA every year. I don't have an issue with that. DIM is another one, Lisa. I use it. I forgot to mention it in that list. DIM is a much, I'm sorry I forgot to mention it. I3C, DIM, indole 3 carbinol and DIM. One is a precursor of the other. They come from broccoli. They are also aromatase inhibitors, but they are much slower. I used to use it and I still use it whenever I get it for all my patients. So when I'm using DIM and I3C DIM, I give it to all patients whom I give testosterone, irrespective of whether they're aromatizing or not. Everybody gets it. So if you're using I3C DIM, I completely forgot to put it in this thing. I'm sorry. But it was in my other presentation. Somehow I forgot to put that one slide. Yes, DIM is a very good. You get I3C DIM. One is the precursor of the other. DIM is the precursor of I3C. Indol 3-carbinol, diindol methane. These come from broccoli. It's excellent for women as well to prevent any kind of breast cancer and uterine cancer. It's excellent. You can use it because it is an aromatase inhibitor, natural aromatase inhibitor, with no side effects, and it's a very slow effect and very good effect. See, I don't feel that there is an Arimidex high dose. Ideal dose for them is 0.1 to 0.5 mg once a week. Not required to give more. Why would you want to give more if you don't want to give it? It's got other side effects. It's a chemical. Dr. Arisi, no. See, the circadian rhythm is for you to test testosterone. That means it is produced in the morning, so you will get the better levels of it. During the day, it gets occupied, it goes to the receptors, it does its job, so the levels will be low. That circadian rhythm is for you for testing, not when you want to give it as a transdermal cream. Transdermal cream, you would want to have your testosterone levels good right through the day, because testosterone is required right through the day. You may not want it to be high in the night because you will otherwise be jumping around. You will not be able to sleep. So yes, when you give it in the morning, as testosterone is applied in the morning, and you're using a liposomal cream, it has about an 8 hours to 12 hours duration where it gives a good level, and then it starts slowly tapering down for the night, and then you give it again in the morning like your diurnal. So in the morning, you get a high dose. That is how it has to work. So I have, Catherine, this is for you. I don't know why he said to give testosterone injection for sleep apnea patients, but the only thing I can tell you is most sleep apnea patients have got a lot of metabolic syndrome. If you give testosterone injections to these patients, metabolic syndrome starts coming down, the fat starts coming down, the heavy weight that causes sleep apnea starts coming down. And indirectly, you would help these patients to get rid of sleep apnea permanently. That could be one of the reasons that I can explain it to you. I have not used it for that, but you could try it, because if you actually have, see, your job is to first check the testosterone levels, not because he's got sleep apnea. If his testosterone levels are low, supplement it. Getting rid of his sleep apnea would be a beneficial side effect. Your job is to do it if you find your patient having less testosterone levels. Have we got that, Catherine?
Hi, Doc. This is Catherine. I'm sorry. The doctor said don't give testosterone injection to sleep apnea patient.
Don't give. Yes.
Don't give.
So I don't know why did he say not to give, but it could be because the patient will not get proper sleep either way if you give him a testosterone injection. That is the only reason why I can think of it. But if you decide to do supplement the testosterone, it is not on the basis whether the patient has got sleep apnea or not. It is purely based on his testosterone levels. So if you have a sleep apnea patient and you need to supplement him with testosterone, and if somebody has told you don't use injections, please go and use transdermal creams. There's not an issue, because transdermal cream is a very, very slow increase of testosterone. Now, what happens with injections is that initially in the first 3-4 days, there is quite a peak that comes in. And that peak can cause sleep disturbances in sleep apnea patients and can worsen sleep apnea. I think he's right in that. Now I'm thinking back and applying it. Yes, you should not be giving injections to them. Dr. Lee Sankey, what type of zinc do you use? How many milligrams of metallic zinc? See, 50 to 100 milligrams is what I would use. I would prefer zinc glycinate, zinc chelate, or zinc orotate to some extent, but zinc glycinate or zinc chelate are two that I prefer. Zinc bisglycinate also is something that is available. I have a patient, this is Indira. I have a patient, 62 years old, medical history, prostatectomy, etc., prostate cancer. If he has got prostatectomy done, the entire prostate is removed, you can give him testosterone undeconate. And anyway, testosterone undeconate does not aromatize. It does not go to the liver, doesn't. So you can give, but you need to still keep a check on the estradiol levels. I have a patient with medical history, prostatectomy. I've just answered that, I think. Indira, you've asked it twice. Yeah, so what happens if you've already got prostatic cancer, it's removed, there is no metastasis, you can check estradiol levels, give testosterone undeconate 145 and 90. Testosterone undeconate does not go through the first pass effect, does not enter your get metabolized in the liver, as a result of which there is a chance that it will not aromatize. Testosterone undeconate does not aromatize, but despite that, I still say you will need to check your estradiol levels properly. So also you will have to check 5-DHT levels as well. Remember, once testosterone gets converted to 5-DHT or aromatase, or aromatized to estradiol, it does not convert back. Okay, it's lost. Yeah, so there is, John, I have seen this not only with Nebido, I have seen it with even transdermal creams. If you feel that there is loss of effectiveness, you need to let the testosterone get washed out. Why? Because most of the testosterone receptors are blocked with testosterone that you have, exogenous testosterone that you have used. And you need it to get washed out. So you may need to actually stop the testosterone replacement for at least 6 months and then start it on a much lower dose and slowly come back up. And then you see the patient improving. I've had 2 patients like this where we worked with them like this. They were patient. We explained to them, they were being treated by some other doctor. We told them they'll have to stop. One of them stopped for a year. The other stopped for about 9 months. But we kept checking their levels at all times, and we showed them that their levels were down. And then we started them on transdermals with the right supplements to go with it. And again, we kept checking their levels. And about 6 to 8 months after that, they realized that the testosterone was working for them. So it was a good 1.5 years for one patient and a good 2 years down the line for another patient till we got him back on testosterone working. So if you have any patient who seems to be resistant, you need to stop the testosterone treatment and wait for it to get washed out for at least 6 months. Have you got this, John? Any more questions?
No more questions?
So for those of you who have still not attended my IV therapy workshop, I have one happening this month end, 27th, 28th, 29th.
Yep. Yeah, I will broadcast what Dr. Pallavi sent me, Doc, about that too.
Yes,
Yeah.
just wanted to remind those who may want to do it.
Yep.
Okay,
You have...
John Zhu has sent another question. Usually I compound testoprogesterone and give it at night for men with insomnia. I don't know how successful you are with that, John, because testosterone, when you give, there's a little bit of a spike and you generally get a little more excitable. I don't know whether the patient will go to sleep even if you put a little bit of progesterone there. If I were you, I would use testosterone in the morning and a very small dose of progesterone in the night. I would break it up into 2 for better effect. Welcome, John. Welcome. That was a very intelligent question. Thank you so much for that question.
Just to share, Doc, for patients that I treated with TRT for testosterone, I usually always prescribe the transdermal cream with the progesterone, a little bit of progesterone in it, because I thought that that could work on both for the 5-alpha reductase and the aromatase.
Correct.
So,
that is a new prescribing tip that people give today.
okay. Also for those that needs testosterone therapy but have a history of prostate cancer, I usually check their estrogen metabolism first and support that together with the TRT and start that too.
Yes, that is another way to do it. That's a very good way to do it. That's what I said. If you have a patient with cancer, first check his estrogen metabolism.
Yep.
Yeah. Check that, and then from there you start coming back.
Yep.
Any more questions? Lovely group. Was great. I feel back normal. Having spoken
Glad to have you back.
Yeah, we were so worried.
I think the energy levels are back. So if I could do it for about an hour and a half, I think I can do it more.
Yeah. So Doc, your next chelation is 27th of this month, is it? 27th,
Yes,
28th, 29th?
28th, 29th, yeah.
Right. Okay.
Because towards the end of the month, because in the middle of the month, which I normally have it at, is Diwali. So
Diwali,
15th
yeah.
is Diwali. So most people in India will not be able to attend.
Yeah, Little India here. There's an area here in Singapore called Little India, and they're already full of Diwali decoration. It's very pretty.
So we are all bracing up for a second or third wave here in India. Delhi is already booming with cases of COVID.
Yeah.
Doc Lenny,
Okay.
we have another questions, I guess.
Yes, John. It's correct. If you have raised estradiol, there is always a chance of prostatic cancer. Arsenic is always known to be a carcinogen, not only for prostatic cancer, but for a lot of other things. So yes, that the both, I mean, it's highly probable. But please always remember something. If you don't want to have any complication with testosterone supplementation, always check estradiol and DHT while you are doing the supplementation. Always. I will definitely, I always try to bring E2 below 25 before I start any testosterone replacement. Even if I don't do testosterone replacement, if my patient is above the age of 40 and say he comes to me and his estradiol levels are about 70, 80, I will certainly put him on Arimidex and bring it down. Because I'm giving him a favor, I'm doing him a favor. I gave you the range. It's about. I prefer it below 25 picograms per deciliter. I think that's the one. Yeah, picograms per ml, not deciliter, per ml. I like the estradiol levels less than that. So what was it? Because in Singapore we can't pick up anything below 37. What is it that you're using? What are you using? Serum? Are you using? And what is the unit that you're using? 37 what? Something wrong with your lab. It has to be less than 25. It is PG
Dr. John?
per ml. This should be your PG per ml.
Let me just check what was the units that we used. Mole per liter.
Okay, so this is a little different. This is,
Yeah.
so if it is 37, yes, you will not get it less than 37. It's 10 times more than what I am asking you for.
Yes.
So there
What
it
is
would
the,
be somewhere around. So
what
you'll have
would
to
be the
convert
top of
it
your
in
range?
Yeah, so this is picograms per ml, and that is per liter.
Picomoles per liter. Yeah.
Yes. So
it's okay. What I would look at is aiming for the bottom 1/3 or bottom quartile of the range that we have.
correct.
So,
Correct.
okay,
That would be another easier way of doing it.
Yeah. So whatever lab that we use, I'll just use a bottom quartile or bottom 1/3. But I wouldn't want to drive it all the way to the bottom, like undetectable, because I think
No, it should not be undetectable. You should try and bring it to the bottom third, and you'll never get it undetectable. People who have high estradiol levels never go down to an undetectable range. Take it from me. It is very difficult for you to get them to the bottom quartile. Very difficult. I have had such issues with patients. It's taken me months and months of treatment to get them down.
Right. Arimidex it works quite well. It's got about...
Yeah, Arimidex is the only one that works quickly.
Yes.
But you must always remember the day you stop it, there's a rebound. It comes back.
Yes. And it stays in the system for about 7 to 10 days. So it's quite an elegant solution. I usually do a loading dose of 1 milligrams 3 times a week. Then after that, I halve that and then keep it running at that.
Exactly. You can do that as well. You can do a loading dose, and then you can give just 1 per week, and that's it. Maintenance dose, even 0.5 mg will do.
Yeah. Great stuff. Good to hear you again, sir.
Pleasure's mine. Pleasure's mine.
Yes.
Is there any more questions, doctors? Okay, if there is no other questions, could we took photos for today's session? Oh, I'm sorry, Dr. Sarah.
Oh, it's okay. I don't have any more questions. So let's take a picture.
Bu In, are you ready, Bu In? So for all of the college, please turn on your videos because we will take photos and so we can see all your face. Bu In. Bu In siap ya? Oke. Aba-aba dong, Bu.
1, 2, 3. Belum semua ya? Oke. Yang lain mana videonya? Dibuka dong, please.
Dr. Sangkili.
Oke.
Dr. Yeni, Dr. Haya, Dr. Heni, Dr. Aris, Dr. Jeffney, Dr. Penny, Bu Susani, Dr. Anggi. Please turn on your videos.
Congestion on Bukit Timah Road. You are on the fastest route. You should reach your destination by 1842.
Kita yang ada dulu ya. 3, 2, 1, cheers. Sekali lagi. Oke. Belum ada yang buka lagi ya video tidak bisa. Masih ada yang belum buka.
Put your mask on properly. They do avoid it.
Done?
Yep. Sekali lagi. One more.
Lisa, have you done?
Yep. Ya. Dok, Lisa, sudah.
Yeah, we're done, Doc.
Awesome. So can I leave?
Thank you so much, doctor. Really appreciate that. Yeah, you can.
Yeah.
Thank you.
Yeah, thank you so much,
I
Doc.
need to
Get well.
Yeah, sure. And let's hope a few of you can join me at the end of the month.
Yes.
Bye.
Yes.
Yes.
Bye.
Thank you,
Thank you so
Doc.
Thank
much.
you,
Bye.
Doctor. Thank you,
See you
Dr.
next
Lenny.
time.
Bye. Bye, guys. Thank you. Thank you, doctors.
Thank you, Doc. Please do not leave first because I have few announcements regarding next week's sessions. On the flyer, it was said that we will have the sessions on November 13. That is incorrect, and the fault is totally mine. So we will have next sessions on November 14, which is happening on Saturday at 8 a.m. So Saturday, 8 a.m. on that is Jakarta time. So for Cambodia, for India, please make sure that you can ask me what time is it by WhatsApp. And so yes, and also for Professor Ahmed, which is the genetic, on the flyer, it was said that we will have his sessions on November 28th, but he requested to be rescheduled on November 27, which is on Friday 9 a.m. So there will be 2 changes. Thank you.
Will you remind us again through the WhatsApp?
Yes. Yes. We will do that, Doc. But this is just so everyone gets an update of the schedules. So yes, yeah, we will give you an update each usually one day before.
Sure.
Okay. Thank you, doctors.
Thank you. So the next one will be the 14th first. Okay.
Yes. Thank you. Okay. See you next week, all. Thank you so much.
Bye.
Bye.